So it is highly subjective, as I already said, and depends on several factors. Now let us take this example of a closed funnel RD. All right, so sorry for that interruption. So this is a case of what looks like a closed funnel RD. The disc is not seen. There is a tough membrane at the disc closing it totally and not seen at all. So all that was necessary was to pick up this membrane and pull it off, and then you can see that what looked very difficult actually turns out to be simpler than what it appeared in the beginning. So this is an example of why you should attempt more and more difficult cases. I'm not going to show you the whole video, but this is just an introduction to show you that what looks very difficult can actually turn out to be simpler than expected. Compared with this one, which is actually a combined case of a complicated cataract as a result of a chronic RD. So we did a combined surgery, a phacoemulsification followed by this type of a retinal detachment. You can see how extreme the retina is, how extreme the phimosis at the equator is, which is pulling the equatorial retina down to the center of the eye and almost causing a phimosis-like appearance. And this is the surgery in progress. You can see that the phimosis is being broken at different places in different meridians. It is so tough, and the retina underlying is so thin that it is very, very difficult not to cause an iatrogenic complication at that particular point where you're trying to peel these membranes or cutting these membranes from the surface of the retina. And that is the time when I put the PFCL to gain access to the posterior pole, and then some posterior dissection. Actually, we have to do the posterior dissection first, but then if you have a phimosed anterior segment, anterior retina, you don't have access to the posterior retina. So what I did was I removed the anterior retinal fibrosis in the beginning to gain access to the posterior segment. So this is actually the peeling at the posterior pole by using forceps, spatula, cutter. Almost all the instruments that we use in vitreoretinal surgery can be used in different situations to try and relieve the traction, especially with the MIVS now being in vogue. So that's again addressing the peripheral retina. The fibrosis has been, most of it has been removed, the tough part, and now we are left with some membranes. And with this, we are able to put in more PFCL so that we get more support to the posterior retina, and we are able to access and actually address the peripheral retinal PVR. So you can see initially nothing was seen, the retina was not seen at all. Now you are able to see more and more of the retina by what I call as peel, fill, and cut, the sequence of the steps that we do. So some more PFCL and some more anterior dissection, with the result that most of the peripheral retina is also getting mobilized, and we are able now to reattach the extreme periphery as well. So that is the way by which we can probably tackle these extremely difficult cases. Patience is the key, of course. And then laser, of course. We have to do the laser to the periphery. In most of these cases where there are iatrogenic breaks and pre-existing breaks, we have to do a 360 degrees laser. Right. So that is the laser with indentation. We need to do this so that any small amount of subretinal fluid that may be present in the periphery is shifted away from there, and we are able to do more laser in these patients. Another case of an intravitreal cysticercus with a complicated retinal detachment in a 17-year-old boy. You can see that the intravitreal cysticercus is there in the inferotemporal quadrant in the inferior retina with a retinal detachment that is very, very chronic, severe, with a lot of PVR, extremely atrophic retina, and very, very thick membranes. So this firmly encapsulated cysticercus is being removed, the membrane covering it is being removed, and we are having some access to the cysticercus itself. And the membrane is totally removed so that the cysticercus is removed and mobilized. And then we do some more dissection using chandelier assisted by manual techniques, because the severity of the PVR is so much that we have to resort to these bimanual techniques, especially because the underlying retina is very, very thin, and if you try to pull the membranes, even a slight pull on the membranes can result in iatrogenic breaks. And then we removed the cysticercus by making an anterior incision in the at the limbus, and holding this cysticercus with the extrusion needle, it was removed through the limbal incision out of the eye in toto without rupturing it, and you can see the cysticercus there with the scolex intact. Followed by some more dissection of the retina, and you can see the end result. I'll just skip this part. You can see that in the end we have a flat retina. With the help of more dissection, PFCL assisted traction removal and laser, we are able to reattach this retina, and this patient has today a vision of 2 feet. From nothing, from a questionable PL to 2 feet vision, this patient has improved over a period of 4 months. Another case of a traumatic retinal detachment in an 18-year-old boy who had been operated 4 times in the past, and this was his picture. Peripheral retinectomies, membranes all over the retina, extremely thin retina, and see these large breaks here. The large breaks right at the posterior pole next to the macula, one here, and probably subretinal silicone oil, which I'll be showing in the video. So this is what we did for this boy. Membrane removal very, very patiently. You can see the breaks threatening to enlarge and threatening to extend, but it has to be done extremely gently. Removal of these membranes, removal of the membrane on the other side of the break. The subretinal silicone oil is actually dancing there, you can see that. And then we remove these membranes with the cutter. Removal of the subretinal silicone oil with the help of the cutter itself, it was possible to remove most of it, in fact, entirely. And then what I did differently in this patient was I peeled the ILM because of the posterior location of the breaks. I felt I should peel the ILM around these large breaks. Otherwise, there was no possibility of them closing or unrolling. The size of the breaks was so large that you will see in the next final result. This was the end of the surgery, fluid air exchange with endo drainage through the breaks, laser, and this is the preoperative picture, and this is the postoperative picture. It is unbelievable that such a large break, large looking break, actually was not so large. It was actually rolled over, and that is why it was appearing large. And once we removed the ILM around the break, it was possible to reposition the flap and make it slit-like, and the end result was quite satisfactory. A case of a GRT, which was not obeying me, because whenever I put PFCL and it used to settle, but then when I was trying to do the air exchange, PFCL air exchange, it was again slipping. This happened 2 times, and I thought I'll look and I'll go inside and see what's happening. And this is what I found. So what I did was I put in fluid again in the eye. After 2 exchanges of PFCL, I put in fluid again, and I went to the back of the retina and found that there were multiple subretinal gliotic bands. So this is what I did. Some of the membranes I had to remove bimanually. So what I'm trying to show here is that patients can have subretinal proliferation, which although apparently may not be the cause of the non-reattachment, we have to look for them and remove them, without which we will not be able to reattach these difficult retinas. So removal of these subretinal gliotic bands from the underlying surface of the GRT, that resulted in a success. I'll skip this. Yeah, this is, I think, a video which I am very proud to show. A blind school boy who had a complicated cataract with a funnel-shaped RD, not only posteriorly but also anteriorly. And what we did for this boy was initially a lensectomy, obviously. Pars plana lensectomy, taking care not to pass the infusion until we could see. So that is why I'm using the needle as an infusion and using the cutter from the other side, doing the lensectomy with the infusion needle always seen at the pupil. Once the lens was removed, we could see that the retina was bunched up behind the lens. That's a totally bunched up retina. And this was actually totally inoperable. We thought we would leave him alone, but because that was the better eye, the other eye was thesical, we thought we'll try and do something and abandon it only if it comes to. So the peripheral dissection is in progress, and you can see that a lot of membranes I had to remove in order to be able to pass the infusion in the first place. So then it was possible, after removing the membranes, to pass the infusion and check it that it has passed freely into the vitreous cavity, and then only it was turned on. And then I could probably pass my light pipe in order to do the proper vitrectomy. And this is how the retina was inside. This is the other continuation of the same video, which shows how difficult it was to remove these membranes which were holding the retina. And this is the fluid exchange which I did from time to time through one of the breaks that was there. You can see the retina going back, at least partly. And then I could have access to the disc area where I could see a lot of membranes, and I removed these membranes successfully with more and more opening of. This is just to show you that it was almost like I had to cut through the forest in order to reach my goal. So that is another fluid exchange that I'm doing to reattach the retina and get more and more view of the disc area. And this was the time when I could probably put in some PFCL and have a better look at the posterior pole and reassess the situation. So you can see what looked totally inoperable became like this towards the end of the surgery. And then onwards it was easy. Some more peripheral dissection, followed by laser. And this was actually, this blind school boy is probably one of the most ambulatory boys now in his school. In all these cases, encircling band is a must, because we don't know how much of traction we have left behind, and it always makes sense to put an encircling band and create a false aura and reduce the the equatorial diameter in these patients. Well, this is my last slide. I hope that I have the audio, because this is a classical music that I put in here. Look at the lyrics at the bottom, translation of the lyrics. A GRT. The bee is trapped inside, but it is unnerved. In this case, the bee is me. So, focus and patience is the key. If you want to get the nectar at the end, if you have to have a sweet ending, I think you have to work hard and not bother about what is troubling you throughout the surgery. Thank you very much.